just, we'll start out just by asking you what area of, or what concepts are most challenging to you from weeks 4 to current week? I mean, we can just jump into anything, but I wanted to see where you were and what your needs are.
I just know that like my grades in the beginning were pretty good, but then like as we've gone on, they just have been like dropping like significantly, and I don't really understand what I'm not picking up on. That's kind of the thing.
Okay, okay. And it's kind of hard to know after that first exam, isn't it? When you think about the quizzes that we're doing at the beginning of class this quarter, you know, we do them at the beginning because we want you to really prepare before class so that you can participate during class. I know that all of you are very, very busy with other classes, clinical simulations, labs, family, and eventually sleep, right? So it's really hard to be organized. And so I would recommend that you just set aside, you know, make a schedule and be very, very diligent at keeping that schedule. What day are you focusing on OB? What, you know, according to your schedule, when is a time that you can say, I'm doing OB at this time, and then every week, the same time, okay? That way you're not sitting there when you're working on OB and thinking about, I got med surg to do. Well, you've got your time set aside for med surg as well. So sometimes that just getting organized. Being a nurse, we have to learn how to organize. Okay. Organize and prioritize is all about nursing. Okay. All right. So I know that you really need to understand preeclampsia. You need to understand postpartum hemorrhage, and you need to know about diabetes for this NEST exam. And these are important concepts that you would need to know for the NCLEX anyway. So preterm labor, and just a good postpartum assessment. So what should we start with?
Preeclampsia.
Preeclampsia. Okay, so if you have a client that has a history of, okay, close that. Maybe she's obese, so she has a high risk for preeclampsia. So what are some other things that would put a client at risk for preeclampsia?
Hypertension. Hypertension.
Hypertension. Okay, what else?
Would it be if she had preeclampsia in a previous?
Yes. Yeah. Family history of preeclampsia. Okay. Diabetes.
Diabetes.
Yeah. Anything that could lend toward an unhealthy placenta. So African Americans, unfortunately, they're at risk. So are diabetics, I already said, but nicotine use, drug use, okay, poor nutrition, obesity, high blood pressure was mentioned by Ashley. So all of those things can lend to preeclampsia. Anything else? Did I miss something? Okay. So what are some signs? If you had a client show up in
Sorry, I have a question.
Yes, please.
Would an advanced maternal be one, like being pregnant at like over 30 or 35?
Okay. So age plays a part in that too. Yes.
What-
Age. So
Is it over 35 or over 30?
over 35. It would be
Okay.
35 and over, 40. And then of course our adolescent clients, there is for a lot of things. Because when you think about it, an adolescent is not fully grown. So they're not considered an adult. Their systems are still growing and maturing. Okay. So what are the signs that you would expect to see in your client? Who is-
protein in their urine.
Okay. So what is a scenario? Somebody give me a scenario, like a case story. Can anybody do that? Is there anybody able to give me just a brief initial story that
So you have,
I could try.
sorry.
Oh,
Okay,
go ahead.
Kathy, go ahead.
Okay, so you have a 32-year-old mom, that's, this is her Grava 2. Let's see, Grava 2. I want to get the letters right because I get twisted up on those. Grava
Okay.
2, P1, and 0 for the board, the A1. Okay.
Okay, okay.
So,
Okay, go ahead. I'm sorry.
so she has a previous history of smoking,
Okay.
which she stopped 5 years ago after the second pregnancy. Pre-diabetic, and blood pressures have been running anywhere from the 130s, 130/90, to 150/95 at
Okay.
times.
Okay. So is that a chronic high blood pressure?
Yes.
Okay. Okay.
So she was
So-
pre-hypertensive before she even got pregnant.
Okay. All right. So she definitely has some risk factors, doesn't she?
Mhm.
Okay. Now let me ask you a quick question. Does high blood pressure cause preeclampsia?
No.
No.
No,
Mm-mm.
No, it doesn't. No, it doesn't. It's because it's the placenta. Okay. Preeclampsia is all about a placenta. Okay. So, so we've got the risk factors. So, Kathy has given us a medical history on a client. So what about her client would suggest, what are you seeing or cues she might comment on, a client might comment on that you begin to suspect early signs of preeclampsia or symptoms?
Vision changes, headache.
Okay, so she calls the office and says she's got a headache and it won't go away. She's tried Tylenol, the maximum dose. Okay, what else might she complain about?
something with her urine. We can do lab work to see if it's protein or something in the urine.
She could have a higher history or occurrence of UTIs from the from bacteria going towards the sugar.
Okay. I'm not sure I follow that.
Maybe it was, I'm thinking of diabetes, or are we talking about diabetes or
We're
preeclampsia?
talking
I
about
missed that.
preeclampsia. Yeah,
Okay,
preeclampsia.
skip that. I'll save that for
Okay,
diabetes.
yeah, save that for diabetes. Okay, good. All right. So Ashley says we need to do some lab work. Okay. So if she calls and she has a headache, what would be your recommendation? Jennifer, if you are working in an OB office and you had one of your clients that was 32 weeks pregnant, let's say it was Kathy's client, and she says she has a headache. What can she do? She's tried Tylenol. Can you give me something else for my headache? What would you say to her, Jennifer?
If she's tried Tylenol and it's not taking it away, I would ask her to come into the office so we could check her.
Good. And what would you want to check?
We're gonna check her urine for well, no, more hypertension. We're gonna check her blood pressure.
We're going to check her blood pressure. Yeah. And then like Ashley said, we probably could check her urine too, to see if there is any protein in her urine. So let's
Okay.
say her blood pressure is high. It's 148/90. And she has this headache. We could go ahead and say she's got preeclampsia. Okay. At that point, that's all we need. We
Okay.
only need high blood pressure and one other sign to diagnose her. So, but we are good nurses and we know we need some more information, right? We want to know how far along this preeclampsia is. So we're checking her urine. What other things do we need to check?
For edema,
Okay, so she might have some edema developing already. Yeah. Okay, what else?
Do we need to do a CBC or BMP?
Okay, so we need to do some lab work. So why do we need a CMP? What would that tell us?
I don't know if magnesium is in there, but I know her regular stuff like her potassium, sodium, chloride, all those things are in it.
Okay, so a CMP, we also need to know the liver enzymes. That's the piece of information we need from the chemistry. Okay, so liver enzymes. Okay, what piece of information do we need that's related to preeclampsia in a CBC?
Platelet.
The platelets.
Platelets, yeah, because with preeclampsia, they drop, right? Platelets drop. And liver enzymes go up because the liver is being affected by the reduced perfusion of the liver because of preeclampsia. Okay, what else?
Cerebral and visual changes.
Okay, so we're going to ask her more about she's seen any flashes and things like that. Okay.
Are we gonna, don't we want to check the baby? So are we gonna do an ultrasound to see if the baby okay?
Okay, okay, all right. Felicia wants to do a quick ultrasound, make sure the baby's doing fine. What else?
Or ask about rapid weight gain.
Okay, has she gained weight? And we should know that because she's coming into the office every 2 weeks. So maybe she's put on 10, 15 pounds in the last 2 weeks. So that's a sign of preeclampsia as well. Okay. All right, so that covers a lot of things that she might complain about and are easily assessed. We can also check creatinine level. What is creatinine tell us? In the
Liver
blood.
function, kidney function.
Kidney function, okay? So because preeclampsia affects the brain, the lungs, the liver, and the kidneys, we need to do blood work that would tell us information about those organs, along with the client's signs, okay? So let's say we decided, Kathy decided she really wanted to admit her. And we're gonna put her in the hospital and we're doing all this blood work. What are some things we want to do? And Felicia wants to monitor the baby. Definitely need to monitor the baby. As you admit your client and you have work done on your client, your chemistry, your vital signs, your CBC, and all those things, what else do you want to accomplish?
We want to stop labor, right? We don't want I guess, her to go into labor.
Okay.
What
No.
about her pain, the headache?
Oh,
Okay.
so we're talking about the headaches.
I'm just asking you, what do you want to do?
Oh.
You wanna
Pain
lower the blood
management.
pressure. Manage the blood
Management. How do we manage things? What do we want to address first?
Put in the IV.
About physiological stability. You have a client who has headaches, her blood pressure is up, you know she's got preeclampsia, you're getting labs drawn, you've hooked her up to monitors, you're monitoring if she's having any contractions, but she's not.
You
Okay.
want to give her some oxygen?
Oxygen,
Why
Magnesium,
does she need oxygen?
because of the headaches.
The platelets are going down.
Okay, so
What-
the platelets are low. What does that have to do with oxygen?
magnesium sulfate, or
Magnesium sulfate.
Oh, okay.
We need to start some magnesium for this woman. You know, she has a headache. She's got central nervous system irritability.
So lower like the stimuli
Okay, we can
and the lights and
do
whatnot.
stimuli. So we're trying to prevent eclampsia, right?
Yeah.
Seizure.
Eclampsia is seizure activity. So if she has got a headache and maybe seeing flashes of light, her cerebral blood vessels are irritated.
Mhm.
And we do
Okay.
not want her to have a seizure. She's got hyper active reflexes, deep tendon reflexes.
Mhm.
She has brisk knee reflex, patellar reflex. She might have clonus. So she could have a seizure at any minute. So your priority is reduce seizures. Okay, the nursing care plan is going to be about reduce the risk of injury to mother and baby, and that means seizure precautions. So Dawn said we need to start magnesium. Absolutely.
Okay.
How do we start magnesium?
IV.
What kind of prescription would you expect?
IV.
IV.
A bolus to 4 to 6 grams.
Okay, so we need a bolus. That means we need to get it into our system. Okay.
Okay.
And so 4 to 6 grams. Good. What else? And then what?
And 2 to 3 grams per hour.
Okay, so we're going to give her a maintenance solution. So we're going to start out small. We don't want to do a whole lot at once because we don't want her becoming toxic. So preeclampsia, we're protecting our client and our baby. Okay. We've got to relax that cerebral tissue. We've got to depress the central nervous system. And that's what magnesium does. Central nervous system depressant. And that will protect her from going into seizures. Okay. So is there anything else you want to do?
We got to monitor us putting that stuff in. We got to monitor her urinary output.
Okay.
And her respiratory.
Okay. Okay, good. So when you think about what is affected by preeclampsia plus what magnesium does, that guides you and lets you know what do you need to monitor now in your client. So you're checking your client every 15, 30 minutes for a while until she's stabilized.
And then make sure you have the antidote in the room also.
Okay, and what is the antidote?
Calcium
Calcium
gluconate.
Calcium gluconate. Okay, so if we get too much magnesium in her system and she becomes toxic, we might need to use some calcium gluconate. Okay. So this is just something I want to show you about preeclampsia. So this is what's going on. If you look on the left side here, let me get that. If you look on the left side here, a normal pregnancy, there's
I can't see anything.
Yeah, we don't see anything.
Okay. That better?
Yes, ma'am.
Yes.
Yeah, there we go.
Okay. So a normal pregnancy is in the middle. If you look on the left side underneath where all the blood flow is, you see that the blood flow at the very bottom of that chart is flowing upward into the intervillous space where the fetal vessels are lining up with the maternal vessels, and there's adequate blood flow, low blood pressure. So that's a nice, healthy placenta. Okay. And then the one on the right, you can see where it's narrowed. Something has disturbed the vessels.
Okay.
Okay. And it clamps down. So the placenta sends out triggers to the rest of the body. And the other 3 or 4 systems that are affected by this, the central nervous system, the lungs, the liver, and the kidneys. Okay. So that's why we are assessing what are the patient's complaints. What do you see? What blood work do you want to do? And what should you, like Felicia said, starting magnesium, then what do we need to assess frequently if we're doing the magnesium? Number 1, is it working? So is the magnesium working? So what would you see in your client when you look at that far right column? What would you see in a client if you knew that your magnesium was being effective?
Yeah,
The blood pressure or the edema. Yeah.
Okay. Blood pressure is going to be controlled a little bit.
You won't complain about the headaches anymore.
Okay, so less headaches.
Increased urine.
Increase urine, yeah. If it's therapeutic, we're going to have good kidney filtration and increased urine. Okay, what else?
Would she have deep tendon reflexes?
Yeah, they would be normal, wouldn't they?
Oh, yeah.
So if it's not therapeutic, then she's going to have hyperactive deep tendon reflexes. But once we get to that therapeutic level on our magnesium, it returns to normal. Okay, so she's not going to have any symptoms. So we're going to see improvement of the labs, her behaviors, and that sort of thing. What would you see if she became toxic? Too much magnesium.
Oh,
Her urine output would be less than 30 an hour.
Okay.
Very drowsy.
Drowsy, lethargic.
Stressed.
Okay, bradycardia, hypotension.
Loss of deep tendon reflex.
Okay, so she might not have many reflexes working. She might even have slurred speech. It's almost like a stroke sometimes, slurred speech. Okay. So the kidneys are very sensitive to magnesium. Okay. So that's why if you have an older client or a child or a baby, magnesium, we have to be very careful. Okay, because it can damage the kidney. Okay, so that's why there's small therapeutic range for kidney. So if there's not enough with preeclampsia, the preeclampsia is going to reduce renal blood flow and therefore less urine. Once we become therapeutic, then that improves renal blood flow and increased urine output. If she becomes toxic, then the kidneys will shut down and there will be little to no urine output. Okay, that's the difference. So keep that in mind when you have a preeclamptic patient. What are you monitoring? What are you monitoring? What do you want? Things that preeclampsia affects. What would happen if things seem to be going well, but her blood pressure shot up and her liver enzymes shot up? What would you suspect is going on?
is that hypertension crisis?
The HELP syndrome thing.
HELP syndrome. Okay.
Oh,
So severe preeclampsia, blood pressure shoots up above 160. And then the liver is really affected. So you're going to see hemolysis, breakdown of red blood cells. You're going to see elevated liver enzymes even more and even less platelets. Okay, so it's about the liver.
And epigastric pain, right?
And epigastric pain, yes. Or right upper quadrant pain. That's where the liver is. That's where the liver is. So your client might have liver pain at that point.
so Professor Zeller, you the HELP, that's actually, okay, I see where the first initial stand for something. Okay, I got it.
Hemolysis, hemolysis.
Hemolysis, elevated liver enzymes, and low platelets.
Yes.
Okay.
Yep, it's about the liver. So any questions about this? How would you know? Go ahead.
I was just gonna ask, in that situation, what do you administer to the patient if they go to that state of
HELP
beyond
syndrome?
control? Yes,
We need to deliver the baby.
deliver the.
So that's the interaction for that.
And it's true, but you know, the only resolve to preeclampsia is to get rid of the placenta. So delivering a baby is a resolve. So it depends how she's doing with the magnesium, how she's faring, monitoring her. If she's only 32 weeks along, we need to probably just, you know, sustain that pregnancy as long as we can. But if HELP develops, we probably need to go ahead and deliver. Okay. How do you know? So some women can actually develop preeclampsia after delivery, even after they go home. For some reason, something is causing the development of headaches. You know, 6 days after delivery, sometimes I'll get a call from a client, I've got a headache. And we just admit them for some magnesium for a while and just monitor them to see how she does. Okay. So But how else might you know? You're discharging your client now. The labor and delivery went fine. Baby's doing okay. We're going to have to keep baby in the hospital a little bit longer, but mom is doing okay. What would you see in your mother that would reassure you that her preeclampsia has been resolved?
You said resolved?
Mhm.
Decreased edema and
Okay.
diastole blood pressure.
Okay, good blood pressure, and go ahead. Muriel.
Oh, I was gonna say, I don't know how to say it, diateresis.
Okay, diaphoresis. That means she's sweating, perspiring. What else?
She's breathing fine. She's not anxious or a whole lot of movement. I mean, just a whole lot of tremors of muscles moving.
Okay,
pretty
she's more
calm.
relaxed.
Oh, and the blood pressure goes down. Is that what you?
Yeah, blood pressure's normal now. Good.
Her
So-
labs are back to normal.
Okay,
Well, like
labs-
elevating, like her liver enzymes and platelets are going back up.
Okay, great. Do you remember we talked about the physiological changes in pregnancy and how the uterus grows and how much blood the uterus has during pregnancy? Up to 3 liters of blood within that uterus. Once you remove the placenta and the uterus clamps down, what happens to all the blood in the uterus?
Oh, it goes back? Does it go back into circulation?
Yeah. So there's a huge volume of fluid that mom has to get rid of. So that's why she's perspiring.
Okay.
She's urinating all the time.
Okay.
Okay, so diaphoresis and diuresis. Okay, those 2 terms, the 2 Ds, which tells you it's been resolved. So she's getting rid of all that excess fluid.
Okay.
Okay. All right.
Professor, you said it's diaphoresis and can you say it again for me?
Let me do this.
The 2 Ds.
I'll type it in for you.
Okay,
So we've
thank you.
got diaphoresis. That means perspiration.
Okay.
Okay. And then the other one is diuresis. That's urinating
Okay.
a lot.
And these are all good things, right?
These are
Because
good
mom is trying to get back together.
Mhm. So diuresis is related to diuretics. Okay. Mhm.
And the decreased edema is also part of it, right? Because they're also releasing fluids.
Exactly.
Okay, just making sure.
Exactly.
So 3 Ds.
Yep.
Okay.
Yeah. Good. All right. Anybody have any more questions about preeclampsia? So what is DIC?
Okay.
That's a descended
Ditch.
something.
It is the decimated intervascular
Vascular coagulation.
coagulation.
Okay, disseminate. That means if we were all in a classroom and I had some chocolate candy, I would be passing it out. I would be disseminating it, distributing it. Okay. So dissemination means to spread throughout the body in this particular situation. It goes throughout all the systems, all the blood. Intravascular means in the blood vessels, right? Inside the blood vessels, in the circulation. So disseminated intravascular, spreading through all the blood vessels, coagulation, which means clots.
Oh, that's a bad thing.
That is a bad thing, yes. Because if you start clotting, then you're not supplying oxygen and nutrients to tissues, and they begin to die. Has anybody ever seen a client with DIC? Look it up on Google sometime and you'll see pictures. They actually have black fingers, bluish black fingers, and toes. So the extremities, the ears and the nose, where the blood has clotted and some of the tissue is dying. So someone who's developing, so for pregnancy, when do we usually see DIC, or when can we see DIC? What has occurred that might lead to DIC most commonly?
Or hemorrhaging?
The placenta.
The placenta detaching. Okay,
Okay.
so like an abrupted placenta.
Yeah.
That's usually when we see DIC begin to form or develop, but not always. It's very rare. Okay, DIC is also seen in regular healthcare. Okay, it's just not known to pregnancy. Now, HELP syndrome you're only going to see in pregnancy. Okay, so DIC. How would you know the difference if it was HELP syndrome or DIC?
PT and PTT.
Okay, okay. Yeah, so for
But
yeah.
DIC or fibrogen also goes down on the labs and your
So does HELP
hemocrat.
syndrome. So fibrinogen is also low in HELP syndrome.
I always, when I think of DIC, I always think of the oozing at the IV site.
Yeah, okay, so you're probably going to see the more serious bleeding, the oozing. I was talking to, was that Mallion I was talking to, didn't know what the word oozing meant? Does everybody know what we mean by oozing?
Yeah.
Okay, it just means to leak out. So blood is going to leak around that IV catheter. Right there at the skin. You might see some bleeding in the mouth, nosebleeds. Of course, vaginal bleeding, lots of it. The client is not able to clot their blood because the coagulopathy has used up all of the protein factors in the blood that can make it clot. So there's no more of those to use. So now we've got bleeding going on.
Now,
So-
would they be, I'm sorry,
Go ahead.
would they be like real tacky, like tachycardia? Okay.
Yeah, and the blood pressure would begin to drop, so going into shock. Okay, so and then hematuria, blood in the urine. Okay, so DIC. And burr cells. Okay. All right.
For DIC, would the treatment also be for her to go get a C-section? Or can they manage that with just like the O2 therapy, a transfusion, and bringing up all her labs and the baby can stay in utero? Or does she need to get a C-section for that?
Well, usually DIC is followed from an abruption. So the abruption is the emergency where we
Okay.
would go do a C-section.
So she would already have had it, and then this is gonna follow after that.
Yeah,
Okay.
yeah. So rushing the OR.
And what causes a DIC?
We don't always know.
Okay.
At least I don't know. I don't think it's known really what really causes it. We know the clients who are susceptible, or some kind of bacteremia, some kind of severe infection can cause DIC. Okay, so somebody tell me, we're gonna switch gears. You have a healthy client and she's just delivered her 5th baby. She's had 4 previous vaginal deliveries and everything went well on her 5th delivery. What is your concern? What is your priority in postpartum assessment? So you're going in the room to see how she's doing. You got report from the nurse? It's been 20 minutes and you're just going to go in and assess your client. What's your priority?
Her uterus.
Okay. So, you know, you've heard of bubbly, but priorities, it's more of an Uber. Okay, so uterine fundus is your priority.
Okay.
Because you have a multi-gravida client, a multiparity client who's got a worn out uterus, it might not contract as easily. She's at risk for postpartum hemorrhage. Okay.
Okay.
What are some other client diagnoses that puts them at risk for postpartum hemorrhage?
That uterine, how do you say it? ATO? I can't pronounce it. I'm sorry.
Atony.
Yeah.
Yeah, you know, yeah, tone means muscle tone. If you're a young person and you exercise, you've got good muscle tone, right? If you're paralyzed, the point of spinal cord damage and distally, those muscles are flaccid, there's no tone. Okay, so atony means no tone. The uterus is not contracting, there's no tone to it. Okay, so uterine atony. What can cause a uterus not to contract? What can cause a uterine to have atony or a boggy uterus?
Isn't it in the book, the 4 T's?
Okay, 4 T's.
It'd be tone, trauma, tissue, and thrombin
Okay.
affect her uterus.
Okay, so tone means it's not able to contract. It's floppy. It needs stimulus or it needs some medication. Trauma can cause postpartum hemorrhage and a floppy uterus. And what was the other one?
It was tissue, like maybe if she had a repair or something like that, or
Tissue
her
means
tissue.
leftover
Oh,
placenta.
from the placenta, retained
fragments,
placenta.
yeah.
Okay.
leftover
And then
placenta.
infection. An
Okay.
infection. Okay, so blood clots and infection. Okay. Over distension of the uterus. So not only multiparity and multigravity, but also maybe a multifetal pregnancy, twins, triplets, or diabetic who had a large baby, and polyhydramnios, a lot of fluid, that uterus is stretched. So we're going to have to watch her. We got to get that uterus to contract. Okay. What are some things, what would you suspect if your client, when you walk in the room and you said hello, you have your gloves on and you checked her armband and she told you who she was, all the safety things, and you went to look at her uterus and you inspected first, which we always do, right? We inspect. What if you saw that her fundus wasn't where it should be? It was kind of deviated.
I would assist her to the bathroom. They empty her bladder.
Okay, so if the bladder's not empty, it's going to prevent that uterus from contracting. So we need to have her empty. But if she can't get up, if she's at an epidural, then we're going to have to sit her on a bedpan or put a catheter in. We have to teach her to keep her bladder empty so her uterus can contract. Okay, all right, let's see. Let's say you went in and you felt her uterus, it was midline, but it was soft. What would you do?
I would give her a massage.
Massage. Yeah.
A fundal massage,
Yeah.
gentle but firm massage. Okay, very good. So what would you do next?
Look
Anybody?
how saturated her pad is.
Okay, before we do that, we do want to assess her bladder, okay? So let's say her uterus firmed up nicely after some massage, her bladder is decompressed. We want to assess her lochia, right? Her lochia. And what would you expect to see 30 minutes postpartum?
Bright red.
Bright red, and what's that called?
Rubra.
Rubra.
Arugula? I
Rubra.
don't know.
Like a ruby. Yeah, rubra. It's French and it's Spanish both. Rubra, right? How do you say red in Spanish? Does somebody know? Do we have any Spanish people here?
Rojo. Rojo.
What?
Rojo.
Rojo.
Okay.
Rojo? Rojo?
Yes, rojo.
Okay. Well, it starts with an R. Okay, yeah. So the Lochia rubra, it lasts for 4 or 5 days, and that's what you're going to see. And so after about 4 or 5 days, then it does lighten up to where it's less blood in it. Okay, and it's what would we call it then?
Serosa.
Serosa. Yeah. So because it has a little bit of decidua, which is leftover area inside the uterus that is sloughed off, and it's not red. It's just tissue decidua and
Like
such.
pinkish?
Okay.
Is a pinkish color, right?
Yeah, it's a pinkish color.
Okay.
In
All right.
Spanish, pink is rosa, so that helps.
Ah, very good. Rosa. Rosa?
Yeah, you
So
got
we're
it right.
saying, okay, so we're saying Rosa.
Yeah.
Good, good, very good. Okay, and then it turns to alba, which lasts another month. Not quite a month, but it's white. All right. So you know Solokia. What else do you want to notice? What else would you want to do or notice?
I guess, I mean, I know we're talking about the patient, but don't we look at the baby bonding and the mother as well?
Yeah, we do, but we got to finish our assessment.
So we're focusing on the patient.
But you know what, Felicia, when you become a registered nurse, you are going to be able to multitask. You're going to be able to see, that baby in that mother's arms while you're doing your perineal checks. Okay.
I heard you.
Do you want to ask her or see if she's experiencing any after pains or anything like that, what her pain level is? And if she
Okay,
had
so-
like a episiotomy, like check that obviously, and make sure there's no
Excellent.
odor developing.
Very good. Yeah. So what is an after pain, Samantha?
The pain after the baby comes out.
Yeah.
Okay.
And what's causing it?
The uterus,
the uterus.
distension.
Yeah.
Mhm. The uterus is
Margot?
contracting.
Like the contraction still?
Yeah, they're contractions. What's causing the contractions?
Isn't the body trying to go back?
Back to normal.
Uterus trying to go back in place and.
After pains. So you're going in, Felicia, you're such an experienced and expert nurse. You know exactly what you would expect when your assessment, and mom has got baby and she's breastfeeding, and you ask her if she's hurting. And she says, yes, I'm having contractions.
It's because of the breastfeeding, the contraction of the yeah.
After pains, yes. So when the baby suckles, that stimulates oxytocin release.
Oh,
Gotcha.
Yeah. So the milk lets down and the uterus contracts.
Okay.
That's why breastfeeding is one of many reasons why it's so beneficial, because it does help that uterus contract. Okay. All right. So we're looking at the perineum. We're looking for any kind of tears, genital tears, lacerations. If she had an episiotomy, which is that intentional incision that we'll do to just allow more room for delivery, that then we have to suture it up. So we're looking at it, make sure it's not bleeding and it's still approximated. We're looking for any bruising, any hematoma development. We're looking for any hemorrhoid activity and her rectum. Okay, good. So let's say the uterus is contracting nicely. She's breastfeeding, no hematoma, but she sure is bleeding a lot. She said she just changed her pad 20 minutes ago, and then you look and it's totally saturated. What could be going on?
I have a laceration.
A laceration. Dawn's on the spot tonight. I tell you what, Dawn, you are just on top of it. Yes, if her uterus is contracting, the blood's not coming from her uterus. It could be a laceration somewhere along, could be cervical. It could be somewhere in the genital tract, the soft tissue in the vagina, or on the floor, a laceration. If we didn't do a episiotomy, it might tear. Okay, so that might be where the bleeding's coming from. But then a hematoma, a vulvar hematoma, or some kind of soft tissue hematoma is not going to develop right away. So maybe 5 or 6 hours later, if your client calls out from the room and says she's hurting, it might be she's developing a hematoma. So a hematoma, remember the deep soft tissue area where the vulva is, and around that whole area underneath deeply, there might be a small blood vessel that is continuing to bleed, and blood is collecting, and it hurts. Okay, so if you see that, you need to, what would you do?
Call the provider.
Notify
Call
the
the
provider.
provider. Yeah, call the provider. You know, applying pressure is not going to help. Ice pack you could do just to give her some comfort until the provider got there. Okay, good. So infant bonding, what kinds of things would you notice in mom that she is doing that you know is really facilitating that bonding, that connection with her newborn?
Making eye
Skin
contact.
contact.
Skin to skin, yeah.
Yeah.
Skin to skin, eye contact, Ashley said.
Breastfeeding.
Breastfeeding. Any of you mothers or fathers that have had a newborn?
I just had a newborn 3 weeks ago.
Oh, wow.
Congratulations.
Congratulations.
Test.
Thank you.
Did you have a boy or girl, Ashley?
A little girl.
And what's her name?
Her name is Harley.
Oh, so how did you act in the hospital when you were holding her?
I know I was overexcited because I already have 3 boys, so she's the only girl.
Oh, yeah.
Yay.
So I was just like,
You're telling everybody, so that's a sign. Telling everybody, talking about the baby,
yes,
stuff like that.
I couldn't
Did you
stop
sing to
staring.
your baby? Did you sing to your baby?
I
Did you
didn't
talk to your
sing,
baby?
but I talked. I talked a lot. Like, oh my goodness, I
Look
still
at you.
talk.
She's still smiling. Look at her. She's
Oh,
smiling.
yeah, of course. Of course. Okay, good. So facilitating. What are some things that you might notice in a client that may be experiencing postpartum blues?
Crying, constant crying.
Okay.
But with blues, it only lasts a little while. It doesn't last a long time. I think
Yeah,
5
it doesn't
days,
last
right?
too long. So what might you see if you go in the room and you kind of think she's got some blues? What things are you seeing?
She's probably not so interactive with the baby.
Right, not as interactive, not,
Yeah.
really not paying a whole lot of attention to the baby, maybe.
Yeah.
Not interested in caring for her own baby.
Yeah.
Okay.
It's not positive, like about the future or like going home and stuff like that.
Yeah. So how would you handle that?
Try to give her support.
Yeah,
Just
maybe
sometimes just listen.
counseling. Yeah.
Give her the resources that, that maybe she could get.
Okay. What else would you want to tell her before she goes home? Bria, are you there? Bria, what do you think? If you had a client that seemed to just really be experiencing some blues, what would you want her to know for sure before she went home?
It's gonna be okay, and it's something that's short-lived.
Okay. But what if it isn't? Can we know that for
And
sure?
there's resources that we can provide to her to ensure that she'll be taken care of.
Okay. So
Let
we
them know
want
it's common, like it's not just them, that like other people feel that way also, and it could be due to like hormonal and just having the baby, so they don't feel so isolated in their feelings.
Okay, good.
And couldn't you give her meds if it seemed like it's gonna be like long term, maybe?
So what you would, good thought, Margot. So what you would also want her to know is that if you continue to have the blues and they're not going away and it's been 10 days or more, you probably need to call your provider
Yeah.
and let them know, because it might develop into an actual depression, right?
Yeah.
And then she might need some, I don't know if she need, it depends on her history. She might not need medication,
Mhm.
but then maybe she would benefit from some. So some kind of counseling, psychotherapy, whatever her provider and her talk about. But she needs to know that, yes, it's common. Hopefully it'll resolve in a few days, but if it doesn't, you need to call your provider.
Yeah.
Or can they
Okay.
make like the post-op appointment sooner than 6 weeks out? Maybe they could see
Oh,
her in
yeah.
like 2
Oh,
weeks.
yeah.
Yeah.
Yeah, if you have someone, if as a nurse, from her history, you've seen her before, and she had this before, you might recommend to her to call your provider and make an earlier appointment. Come back, go
some
see your
people-
provider in 2 weeks instead of 6 weeks. Oh, yeah, yeah.
Professor Zeller, I know that there, for some people that already have the depression problems or
Yeah.
psychological problems, and they have a child, they have different kind of like District 19, send people to your house
Okay,
to see you because you're already fragile. Now
right,
you had this
right.
baby, and that
Yes.
depression don't go nowhere. It just made it worse. So they
So
send
home
this-
care, yeah,
Yeah.
so someone to
Yeah.
come out and check on you, absolutely. That would be a fun job for sure. Good, very good. There's all kinds of resources out there, but we just have to give them to our clients. Okay,
And Professor, I was gonna say with the baby blues and the actual postpartum depression, I heard a lot of people say like it's hard to distinguish the two. Sometimes it can be the same thing, or they think it's the same.
okay, because they do overlap. There's no
Mhm.
definite like, okay, today you're in depression, yesterday it was blues. It does overlap. Okay, there's no definitive line, so they do overlap. Okay.
So
So
the
what-
difference between them are what? One last.
It's a time factor. It's a
Time factor. Okay.
factor.
I just want to be clear on the time factor. Okay.
So can a person with postpartum depression have suicidal ideations?
Yeah, I would.
Yes. Yeah.
It has happened.
Infanticidal, homicidal?
Yeah, it has happened.
Definitely. So what's the difference between depression and psychosis?
Depression, you're
Psychosis
not.
is short-lived. I thought psychosis was short-lived.
No, you have a plan. You have a plan to hurt you.
No,
the
you
baby,
have a plan.
family.
Yeah.
You have
Yeah.
a plan to actually do harm.
Yeah.
And you're hearing
psychosis.
voices and stuff like that.
Wait a minute,
Yep.
wait a minute. Psychosis.
Uh-huh.
Yeah, you have a plan to like harm yourself or the infant, and then the depression is just more of a sadness. You haven't really gotten to that mind frame where you want to harm yourself or the child yet.
Blues, depression, then psychosis
Yeah.
is the most extreme.
Okay, this is in the book, right?
Mhm.
Yes.
Okay, I got it because
Okay,
the
listen.
reason why I'm
I'm not
asking-
that
Wait a
smart
minute,
to make
wait
it
a
up.
minute, wait a minute, wait a
Okay.
minute, wait a minute.
Uh-oh.
Suicidal ideation means that you're thinking about it.
Right,
You could
right,
plan it. You could plan it
right.
and still just be depressed. You don't have to have
Okay.
psychosis.
Okay,
Okay. Psychosis is another ball game.
okay, that's what I thought. Okay.
What
What
is
defines that
psychosis?
one then? Because I feel like the
Psychosis-
other one is super severe. So what comes after that?
Psychosis is super severe and
It is.
has to be hospitalized.
Yeah,
Oh, okay.
yeah,
Psychosis means they need some medication.
right. Okay,
Very
that's what.
severe. So
'cause-
how do you define psychosis?
I thought
Lauren,
psychosis was
Lauren, do you
short-lived.
know? Lauren's quiet, that's why I call on her. Julia, Raven, how do you define psychosis?
I don't know how, I'm
It's like
listening.
a
so I don't-
disconnection from reality.
All right, Lauren, very good.
Okay.
I'm
Good
here, don't
connection.
worry. I'm under the radar, but I am here.
Okay, Lauren, that's fine. You're not required to be above the radar. So yes, disconnect is a perfect way to
Yes.
describe a disconnect, kind of out of touch with reality.
Mhm.
Bizarre, impulsive behavior.
Yeah.
Suicidal, absolutely sometimes. Infanticidal, absolutely sometimes.
Okay.
Homicidal, absolutely. So
Hallucination.
delusional,
Yeah.
delusional, you believe something is occurring when
Yep.
in reality it is not. So that means delusional. Okay, so it's bizarre. It can occur at any time.
So I have a question, Professor, because reason why I said short-lived, anything, because we send people to the hospital and they'll diagnose them really quick. Everything's fine. And then they'll say psychosis, because that's why I thought it was short-lived.
Okay,
It's something that'll come on you all of a sudden. It's not,
short
I
onset.
forgot how they
you mean.
complain.
Yeah, yeah.
explained it.
So I think I know what you mean.
Okay.
So hopefully it is short-lived and we can give medication,
To help.
some antipsychotics to calm them down a little bit and bring them
Okay.
back.
Okay, okay.
Yes. Good thought though. So when are we gonna, who are some clients that are at risk for psychosis?
Schizophrenic,
Okay,
bipolar,
bipolar,
Patients who are alone, don't have the support system.
okay.
Maybe
Okay, so-
substance abuse, or they already have like disparities going into the pregnancy and they don't see any
Okay.
hope or anything like that.
Someone who's never been treated for some kind of depression in the past.
yeah.
Traumatized.
I had a client who had bipolar, and she told me, and she was about 8 weeks pregnant when she came in for her first visit. And she was so excited. She's only 19. She's so excited for this baby. She said, I stopped all my medications. I'm thinking, oh my gosh.
Oh, God.
She stopped all her medications. She says she's doing fine. And she did fine during her pregnancy. At least that's what she was telling me. But she seemed fine. Very reasonable within, she didn't seem like she was out of touch. She wasn't delusional, anything like that. She seemed fine. She had her baby, and about 5 days later, she went into a psychotic state. And so she had to be hospitalized for almost a week.
Oh,
And then when she came to see me for her 6-week appointment and told me all this stuff, I said, next pregnancy, we need to handle a little different. She didn't want to be put on any medications. There are some medications we can use because psychosis is not good. I mean, we don't want our clients to have to experience that. Anyway, okay, enough on that. What else? What's next? So we got postpartum. We didn't complete postpartum hemorrhage. What medications? You need to know your medications to treat postpartum hemorrhage. What is number one?
The
What is
method.
Oxytocin. So just about every client after delivery, when the placenta is being removed, we give a bolus of oxytocin. Okay, to get that uterus contracting. Okay, so then later on we can give another bolus, even if it's infusing. Okay, we need to really be aggressive with postpartum hemorrhage, and it's an expectant treatment. We expect a mother with polyhydramnios to be at risk for bleeding. Okay, so we need to be aggressive. All right. So oxytocin, what would be your next drug of choice? Malian, I think you said it, or no, maybe it wasn't you.
It's the M1, but I don't know how to
The
pronounce
M1.
Methadone.
The Methergin.
Methergin.
Does anybody know how to pronounce the generic form?
No.
Angeline.
Methyllergonidine. 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 Take a song out of it. Okay, methyllergonidine. When do we not want to give this?
Contraindicator for
They have asthma.
hypertension.
Malian. contraindicated for hypertension or some kind of cardiac disease because it's a very strong vasoconstrictor. So it would increase the work of the heart. So nobody with heart disease or high blood pressure, any kind of heart rhythm abnormalities needs methylergotamine. Okay, so it's an injection, intramuscular. Okay, what else could we give her?
Cytec. Cytec.
Amabate.
What'd you say, Kathy?
Ain't it Cytec when we get
Cytotec, yeah, Cytotec and Hemabate, both. Okay, so Hemabate, contraindications?
Asthma.
Asthma. So Raven, it's the Hemabate. Yes. And then what is Cytotec?
Hypertension.
No. What is Cytotec? What's the generic name? And what kind of a drug is it?
Is that misoprostol?
Okay, misoprostol. So it's a prostaglandin. So we can give prostaglandin. It's a lot larger dose than what we would give for induction of labor, right? And we put it in the rectum. The rectum has a lot of blood vessels, so it's absorbed readily. So it's going to cause some really strong contractions. Contraindications for rectal suppositories.
hemorrhoids.
Diarrhea.
It could be. Well, I didn't thought about that. What are some contraindications? When would you not want to put a rectal suppository in the rectum?
An episiotomy.
An episiotomy or some kind of laceration.
Yeah.
Yeah. Okay, good. Y'all been studying. Good. All right. So that worked and things are slowing down and all is going well. Let's talk about diabetes. What is pre-gestational diabetes?
Is diabetes that you get while pregnant?
Pre-gestational diabetes.
Before you get pregnant.
Before you
Yeah.
get pregnant.
So what
Okay.
kind is it?
Type 2.
Type 2.
Type 1 or type 2? Yeah.
Type
Either
2.
one.
Oh, okay.
All right. So tell me, what kinds of things do we kind of plan have our nursing care plan developed around during that first trimester? What are some things that are important?
Monitoring her glucose.
Okay.
Weight control. Well, how much weight she gains.
Okay.
Healthy eating.
Nutrition.
Yeah.
Okay. And those all sound really reasonable, and it's true. In OB, what are we concerned? What is an ideal situation if we have a diabetic that gets pregnant or that wants to get pregnant?
The strength of the uterus. Wouldn't they have problems? I don't know.
It's okay to think out loud. Absolutely. Think out loud.
Mhm.
So what do we really want to be able to do for a diabetic before she gets pregnant?
Control.
Yeah. Have it under control.
Yeah. So preconception counseling, get those sugar levels low before she gets pregnant.
Okay.
Why? Why do we want her to be euglycemic before she's pregnant?
Because if
So that
it's
she's
high and
healthier.
super elevated, they can have like neurotubular issues while they're developing within like as early as the first 8 weeks of pregnancy.
So yeah, we could have some damage to our fetus during the organogenesis. All that glucose around it, actually what we tend to see are cardiac anomalies or limb deformities, things like that. Neural tube defect, maybe so. Okay. So that's why we know that hyperglycemia early in pregnancy carries a high risk to damage that fetus or that embryo and fetus. Okay. So it's ideal that she gets that blood sugar under control prior. So we can do an A1C the very first time we see her if it's early in that first trimester, because it's going to be pretty accurate at that time. And we can get an idea of what's been going on over the last 3 months. But after that point, we don't do A1C. We shouldn't do. It's not recommended. The guidelines don't say continue with A1C because A1C is not that accurate during pregnancy because we've got that hemodilution going on, that physiological dilution of the blood going on. We've got all that extra plasma, so it's not accurate. Okay, so what's our best choice for assessment of glucose on a day-to-day throughout the pregnancy?
Blood glucose.
Yeah, finger sticks
Glucose
or
monitor.
blood draws. Yeah, so the client really has to get involved in her own care. Okay, all right. So during the second trimester, if your client is not being compliant with trying to keep her blood glucose down, she's not meeting the target levels. You have to teach her the target levels early so she knows. So what is the goal 1 hour after she eats a meal? 1 hour postprandial, what is the glucose level goal? What is the range? 1 hour
140?
after. Okay, between 60 and 140, not above 140, not below 60. Okay, what about 2 hours after she eats?
120.
120. So 60 to 120. Fasting when she gets up in the morning.
Between 60 and 95.
Okay, and then before lunch, it's going to be 60 and 105. Okay, you need to know those. Okay, you really do need to know those. It's just an all, and remember in pregnancy, we're much more strict. Why is that?
Because
Why are
it's two
we so
lives
strict?
instead of one. You're
What'd you
dealing
say,
with,
Kathy?
it's two people instead of one, the mother and the
You want to
Okay.
protect the fetus.
Okay. Anybody know why it's so important to be very strict, other than, making sure our baby doesn't get too big?
Because the baby can go into fetal distress in seconds.
Do you think the baby would go into distress before mom?
Yes, maybe because it's smaller. Or no?
gonna be hypoglycemic. The baby will be. I mean, if it's not controlled right after she had, that's a possibility.
That's right, postpartum. You're right, Kathy, you're right. But during the pregnancy, we don't want mother, if her blood glucose is climbing up towards 200 milligrams, she needs to go to the emergency room. She's more susceptible to diabetic ketoacidosis. Okay, so that's why we have to be much more strict, and she needs to understand that. Okay. Okay, so let's talk about some of the other effects of hyperglycemia during the pregnancy besides that. What else might you see during the pregnancy? What is occurring with high glucose levels? When mother is hyperglycemic, so is the baby. Maybe not quite as high, but usually.
Polydipsia.
IUG.
So mother might be experiencing signs of hyperglycemia. Yep. What else?
Is it called neuropathy or something like that?
Let's talk about the fetus. Okay. What effects does it have on the fetus?
Oh,
IUGR.
Not usually.
The baby could have hypoxia.
I'm not sure about
Cause a
that.
miscarriage.
Okay, miscarriage in that first trimester, yes. What about the second and the third trimesters? What are we going to see with all that glucose?
The breathing goes down.
The baby. Let's talk about the
getting-
baby.
Baby's not getting enough oxygen.
From the placenta because it's going into preeclampsia now.
A big baby?
No. A big baby. Dawn does it again. Ding, 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 ding. Yes.
A big baby.
Macrosomia.
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 Oh, okay.
Big baby. Lots of glucose. Man, that baby's just a growing like crazy. Woo. Okay, so with macrosomia and hyperglycemia, other than polydipsia, what other signs mother is having?
Polyuria.
Polyuria, urinating all the time. So does that mean that the fetus is urinating all the time? Yeah.
Yes.
So what happens?
No protein. No. I don't know. Something. Dehydration.
Like excess amniotic fluid or
X says Julia comes in with the right answer. Polyhydramnios. That baby is peeing and making a lot more amniotic fluid. All right, so big baby. So at this point, yes, Samantha was correct. She's at risk for preeclampsia in this pregnancy. So there's also a chance of stillbirth. So stillbirth is the baby has to be beyond 20 weeks and delivery, but the baby's not alive. Okay, so there's increased risk of stillbirth. So baby is gonna, if a macrosomic baby is a baby that's above the 90th percentile or 4,500 grams weight or greater. Okay, so in excess of 9 pounds, close to 10. Okay, so she's in labor now. What are some things that can happen in labor? So many things. I bet I could list a dozen things.
The shoulder.
Shoulder dystocia. Yep.
Dystocia.
Babies, you know, the baby of a diabetic mother has broad shoulders and a broad trunk. So shoulder dystocia is kind of common. What else?
There's a risk she could get a C-section.
Okay.
And then complications that go with that.
Yes. Such as infection, blood clots. Other than a C-section, maybe she could deliver vaginally, but we might have to do like
tearing.
Vacuum.
No.
Or the forceps, and then that could cause like facial paralysis for the baby.
Yep.
Yep.
Lacerations, birth injuries, clavicle fracture, lacerations, hematomas, mom and baby. And then let's say everything was fine, but what about the newborn after delivery? Other than what we've already talked about, what are some things that we're concerned about? Somebody mentioned it earlier. It was
Hypoglycemia.
Kathy. Hypoglycemia.
Hypoglycemia.
Yeah, we've got all this glucose and then we're cutting it off, clamping
So
that cord.
decrease in breathing and really
So
decrease in
respiratory,
breathing.
respiratory distress.
That makes
is-
sense. Mhm.
So why
Like she could go in the
respiratory
labor earlier because of her diabetes and preeclampsia.
That's true,
so
preterm. Okay. So why respiratory distress? What does that have to do with anything?
The lungs are last to develop in the fetus.
That's true. But if she's 36 weeks and the baby still has respiratory distress, what do you think caused that? Not that you really need to completely understand it.
Maybe
Did we get-
polyuria because it was like peeing so much and didn't have enough room.
Is the delivery a C-section?
Sometimes the transient tachypnea of the neonate with the C-section, yes.
Okay, because I do
That's,
know.
that could be
sometimes
one thing, but
they
even
don't-
vaginally, they might experience some respiratory distress. High
it-
insulin levels.
Hi, yeah, that's what I was thinking.
Remember, the insulin resistance increases throughout the pregnancy. It takes more insulin to get that sugar in the cell. So there's high insulin levels, and that reduces the production of the surfactant in the fetal lungs. So they sometimes will experience a short-lived respiratory distress. Wow, that was good. Okay. What else do we have that is important for you to know?
Will we have to know certain medications?
I would know the ones to that manage postpartum hemorrhage for sure.
Okay.
And what about a preterm baby? If you have a client that's 32 weeks pregnant and she calls the office and says she's having low back pain.
What's your question? Like the pharmaceuticals on that, or are we gonna go over like preterm?
Preterm babies, what are the signs of preterm labor?
Pelvic pressure,
And low back pain.
no back pain. Yeah.
Okay. So true labor are regular contractions and cervical changes. So you could have a client that's preterm and she goes into labor. How do we manage that?
With the tocolytics.
Okay. When would you not want to give a tocolytic?
Oh. Mm.
When
Maybe if
would
she has cardiac issues.
Tachycardia.
Tachycardia,
When would you not want to stop labor? If a mother at 32 weeks, when would you not want to stop labor?
If she's in DIC or help.
If she's dilated.
If the baby is in distress.
Well, you're probably right about that, Raven. I'm thinking more of if there's an infection going on.
okay.
Oh.
Because a lot of times preterm labor is caused by an infection.
Okay.
Okay. So we're not going to stop labor if the mother has an infection. Any signs of infection, which would be what?
UTI.
Urinary tract. So what's a sign of an infection?
Fever.
Pain.
White blood
Urinate
count.
when you urinate, maybe.
Okay.
Fetal
Okay.
heart rate is gonna be like in the 170s, 180s.
Okay. So fetal tachycardia, maternal tachycardia, it's a sign of an infection. So we're not going to stop labor because we've got to get that baby out of that infection. Okay. So preterm, we've got to let it carry its course. So what is our care plan in that situation? What are we going to do to protect mom and baby as she begins labor?
We're gonna give her a shot of beta for the baby's lungs to protect the baby, and maybe some antibiotics.
Antibiotics.
Okay, good. So betamethasone to stimulate production of surfactant. Okay.
And magnesium for the babies.
Okay, magnesium for the baby. How does magnesium help the baby?
It reduces the chances of the baby getting spinal bifida. I don't know how to say that.
Not spina bifida.
Oh, what is it?
Neuro.
It improves lung development.
Do you remember what magnesium does?
Isn't
to
it the
Neuroprotection.
surfactant for the lungs?
Neuroprotection.
Neuroprotection. So
I can say neuro.
it improves the blood circulation of the cerebral vessels, which is it's doing what it's doing for mother. That's why she has her headache goes away. Okay, so we're improving the fetal blood flow in the brain, and it helps prevent cerebral palsy. Okay, cerebral palsy, magnesium for the newborn. Okay, so since magnesium sulfate is a central nervous system depressant, it's going to depress the fetal heart rate, maybe just a little bit, maybe more relaxed when they're born, that sort of thing. But it certainly does protect the fetal neuro status. So betamethasone for the fetal lungs, magnesium for the fetal brain, and then antibiotics for the infection. Good, good. So what's a good antibiotic for chorioamnionitis?
Ampicillin.
Penicillin, yeah, yeah.
What was that, penicillin or ampicillin? Penicillin.
Penicillin, yeah. Although, you know, it's not set in stone because some facilities might do something different. And if we have a client that's allergic to it, we have to do a sensitivity test. All right. Let's see. All right, one more topic. What about bleeding in pregnancy? Oh, let me do it this way. All right. You have a client that shows up at ER, and all of you are working as an ER in this huge hospital with this huge emergency room. Okay, triaging. You have a client that shows up and she says, I'm so sick. I've been sick for 4 days and I can't keep anything down. I feel so bad. And you know, she's dehydrated and she says she's pregnant. Okay. What's your priority?
To start her on IV fluids.
Yeah.
All right. All right. We need to get her on IVs. Okay. All right. What would you want to do next?
The baby.
Get some labs.
Ultrasound.
Okay. Labs.
NSC.
Okay. So what labs do you want to get?
If we're suspecting her being dehydrated, as a CMP.
Okay. Because that would give us all her electrolytes.
Mhm.
Yeah.
When someone vomits a lot, they're throwing up acid. So
Oh,
that you could go into a metabolic alkalosis in a short amount of time. Okay, so we do want to get our electrolytes. Good. Labs. What other labs do you want?
To see what her protein is.
Did you get a CBC?
yeah.
Okay. Why would you get a CBC?
Her white blood cell count could be, you know, high.
Okay.
She could have an
But-
infection.
Okay.
And then you
What
say
else?
something about, somebody says about platelets. We need to see the platelets, right?
Well, is she bleeding?
Oh, so we won't have to worry about that. Mm.
What about buns?
Okay, that's part of the chemistry.
Yeah, that's in the CMP.
What do you want to know about the CBC?
Is it
Kathy,
that?
why?
So, wait a minute, I got lost. Do the question again, because I was writing and answering at the same time, so I apologize.
So why do you want a CBC?
To look
Okay.
at her liver and kidneys? To see the levels of the liver and kidneys, or I don't know.
Not with a CBC.
Not with a CBC.
The liver function test that you're gonna do for that. What do the question?
Why are you thinking liver function test? We got a nauseated woman here.
So if she's nauseated, I shouldn't do a CBC. You said the lights would be good because she's gonna be getting rid of her sodium.
Okay.
keeping
Do you
the
want to check your like sodium, potassium, and all that stuff?
That's her electrolytes,
Yes,
okay?
yes.
Okay, let me repeat. You have an 18-year-old, she comes into the emergency room. She says she's been throwing up for 4 days, is not able to even keep water down. And you determine the priority is put an IV in, and then you said you want to do some labs. What else do you want to do?
Check her vitals.
Give her anti-emetic, give her like a Zofran.
Okay, let's give her some relief. Yeah, Dawn does it again. Let's give her some relief. let's give her some antiemetics while we're doing other things, okay? So give her some antiemetics. We've got her labs drawn already. We can't do anything about those until we get the results. Let's get her some relief. And what else do you want to know? What other cues in her history would you use to make your clinical decision? She's been thrown out for 4 days. She's 18 years old. She says she's pregnant. What else do you want to do?
We would find out if she had a bowel movement. Make sure she's not constipated. Sometimes that.
She's not 85 years old. She's 18.
Oh, okay.
Any kind of GI problems?
Okay.
Lifestyle.
Is she eating
I
that
love it.
spicy
This is great.
food?
Acid
Take
reflux.
small meals
Her
or
nutrition.
Maybe a food diary.
She's pregnant. What do you want to do?
Pregnancy test.
She's pregnant.
Okay, so don't we want to see what her HCG is in her blood?
Yeah.
Okay. She might not be able to urinate for you very well if she's dehydrated. So let's just get that drawn along with the lab. So why do we want an HCG?
HCG.
This is what we call.
You want to make sure it's not a molar pregnancy.
All right, Samantha. This is what we call differential diagnosis. What's really going on? She says she's pregnant. Okay. So we're going to go ahead and draw an HCG. What else do we want to do to verify a pregnancy?
Ultrasound.
So an ultrasound is going to tell us if she is pregnant, if it's a normal pregnancy.
Somebody did say something like that.
Yeah.
But what if it's a molar pregnancy?
It'll still look like a growth on the ultrasound. So you have to check it, because if she's only like, would you say 8 weeks, it's just going to be a bleep and that still looks like a mole pregnancy or a fetus developing.
So if it's a molar pregnancy, it's going to be a lot larger than uterus is going to be a lot larger than an 8-week normal pregnancy, but you're not going to see an embryo. You're not going to see any kind of fetal pole or anything. Okay.
Okay.
She's probably in pain and bleeding if she has a molar pregnancy. So that's one reason that you might see some early pregnancy bleeding is because it's a molar pregnancy. So her HCG levels are going to be astronomically high.
So how
Very
would they
high.
word that on like a test or something for that type of situation? Would they ask like somebody comes into the ER and they're suspected of having that? How would you know to pick like
so
an
it would probably be associated with a high HCG level.
Okay.
Nausea. Okay. Okay. So let's say her HCG is typical for an 8-week baby. Things look fine, and she is pregnant. So we've gotten her antiemetics and we've got IV fluid. She's starting to feel a little bit better. Her labs come back and her potassium is 2.8.
That's too low.
That's low.
That's too low.
Yeah.
So we need to give her some potassium.
Yeah.
And some fluid. So we'll probably just keep her for a few hours, get her rehydrated, get her nausea under control, and to prescribe her about 10 different antiemetic medications. So whatever works type thing, get her rehydrated, maybe with a couple liters of fluid if she's that far behind, and send her on her way. Okay. So that's what we call differential. What did you see or hear me say about her history that leads you to suspect possible molar, possible normal pregnancy, or what is another thing that could be occurring?
A miscarriage.
Miscarriage.
Could it be an ectopic pregnancy?
Ectopic, yeah. So if she says she thinks she's about 8 weeks pregnant, our ultrasound is going to tell us where that baby is. Okay. And so her HCG levels might be a little bit below normal. Okay. Okay, good. All right, let's see. I think that's all I had to talk about. Is there anything else you want to talk about?
I would like to see you before we go, Professor Zeller.
You would like to what?
See you after we leave. After
Oh,
it's
okay,
over.
okay, just hang on then. All right. I'm willing to talk about anything else you need to talk about.
Will you,
This
are
was
you gonna be doing
recorded,
this
right?
ever doing it? Are you ever gonna do this again? This was awesome.
It was
On
very helpful.
Sunday. On
Sunday
Sunday.
night, I'll meet with whoever shows up.
Good.
Okay.
What time on Sunday? Is it gonna be on?
Sunday at 7 p.m. Eastern.
Okay, I'll be there.
Thank you so much.
You're welcome, Felicia. I hope it does help.
Thank you.
The way
Thank you.
I learned by hearing.
Yeah.
So hearing
Yeah.
everybody talk helped me.
I will share this recording with your instructors.
Nice,
Okay.
nice. Thank you. Thank you
You're
so much.
welcome.
Thank you.
You're welcome.
And Professor, before I leave, I just wanted to ask you some of the key things you think that should be focused on for the exam. You said, I remember you stated it at the beginning of the class.
The things we were talking about, everything we talked about tonight: postpartum hemorrhage, preeclampsia, diabetes, bleeding, preterm labor, prioritizing, things like that.
Okay, perfect. Alrighty. I'll be back to your review on Sunday. Thank you.
All right, Ashley. You're
Okay.
welcome. Bye-bye. All right. It's taking a while. Oh, well. Later. What? Oh. It's holding up pretty well. That's why you guys can stick with the plan better. And ask this, it was